Hi, everybody. Welcome back at our mini-series on the EUSOBI recommendation, how the EUSOBI recommends to screen women with dense breast. And it's my great privilege again to talk to Dr. Chris Comstock, attending physician at MSKCC Cancer Center, New York, world-class breast imager, which every one of you knows. And he is leading the committee on breast imaging in the ECOG-ACRIN trial. And today, we will have a more detailed talk about his pivotal study comparing abbreviated breast MR with TOMO, digital breast tomosynthesis for breast cancer detection in women with dense breast undergoing screening. So once again, Chris, thank you very much for being here with us today in the second edition. And yeah, the honor is on our side, and let us know what your key points are on this.
Great, thank you for having me. Yeah, so I'd like to just give you a bit of a history and then an overview and maybe future directions that I think are important for this technology. So, I took over the ECOG-ACRIN co-chair of the breast committee, and the legacy was ACRIN, which is the American College of Radiology Imaging Network, which had really, I think, played an important role on evaluating technologies that were kind of percolating out in practice, but people needed direction on where to go with it. And ACRIN studied the DMIS trial, looked at digital versus analog. There was the whole breast screening ultrasound trial, which gave us data on that. And so when I took over the ECOG-ACRIN imaging co-chair at the breast committee, Connie Lehman had passed that down to me, and she said, really, this is your opportunity to do something that you want to do. And, I felt it was time to study MR. And so we convened a mini retreat, and I invited Christiana Kuhl as a co-investigator and Gillian Newstead. And out of that came the concept of doing an abbreviated breast MRI trial. And I think it was really important because most of the data on previously published on ABMR was from patients who underwent a full MR, and then they just stripped out the sequences and did reader studies. And we really wanted to do a prospective multi-center trial looking at the phase 2 performance of abbreviated breast MRI. And so that's where the ECOG-ACRIN EA1141 trial, which was a comparison of ABMR versus digital breast tomosynthesis in women at average to intermediate risk with dense breast tissue. And so this study was a prospective paired design where patients who were scheduled for routine screening DBT, no prior history of MRI or vascular-based screening, and not at high risk. High risk women already get full MRs based on the American Cancer Society guidelines, but these were women at average to intermediate risk with dense breast tissue undergoing just routine screening. And they volunteered to also have this ABMR done in a paired design read by 2 separate radiologists. And so, and the primary aim was to look at the cancer detection rate. We had some discussion with the NCI, and they really wanted us the primary aim to be invasive cancer, because there's a lot of current criticism of overdiagnosis, overtreatment, but that's why we powered it to invasive cancers to show that we were detecting important cancers. But we also reported, obviously, overall cancer detection, which included invasive and DCIS. So in this study, the ABMR was a localizer, obviously, a T2, 1 pre and 1 post. And our definition for the ABMR was it had to be performed in less than 10 minutes. Sites had to have high quality breast MR. They had to be ACR breast MR accredited, followed those resolution parameters, and they had a reader training set to go through. So we qualified the sites, and then we also had a test, a reader training test that they had to take. And so in the end, the study was 1,500 patients. About 1,440 completed both exams, and so were valuable for the data. And it turned out that out of the 44 sites, obviously Christiana Kuhl's site in Germany was one. The rest were in the United States. But there was about a 50-50 split in academic versus private practice, which is really important. Particularly the NCI, promotes this because when you evaluate a modality, you want to know how it's going to perform when it precipitates out across all practices. So that was an important point, that we had a mixture of academic, not just ivory tower academics, but also community-based practices. And interestingly, the accrual window we had given for the study was about 18 months, but we accrued almost 10 months ahead of schedule because, women know the power, they've heard about the power of MRI. And so we accrued very quickly because women want to have their cancers found. And so, but just stepping back, I always felt this trial, this phase 2 study, to me, the point was not really, we already knew that MR is going to find more cancers. To me, this was really a Trojan horse, so to speak. To me, the major goal of this trial was to break the mindset that, MR should only be reserved for that, the super high risk, the 0.1% of the population, but how can we really expand our most sensitive test to a lot more women? And so that was really the goal, I think, of the study. I think MR is eventually going to evolve. Full protocols at some centers are already, 12, 14 minutes. So this idea of an abbreviated MR isn't that, big of a change, but it really needed to be done to kind of prove its utility, break the mindset that, women can't tolerate it, or that they can't, you can't use an IV based mass population screening test, which, women get all sorts of annual physicals and cholesterol tests and blood draws. So, I don't think that having an IV should be an impediment to mass, not mass population, but, much broader population. In this case, women with dense breasts. And so the key take home points from the results were that, and these are sites, most of these sites had never performed, they've been performing full MR. And so 97% of sites were able to perform, 97% of the scans were performed in less than 10 minutes. The average time was 8 minutes. And 96% of women were able to tolerate and complete the MRI, which is an important point, because I know some earlier publications, some of the ultrasound screening publications, cited that, women, not that many women could tolerate MR, which is just, it's not the case. And so those are important phase 2, performance measures, that it was accepted, sites could perform it. And we had very few contrast, only 12 minor out of the 1,500 patients, there were 12 minor reactions. So those were important points. And then the data, which I'll just go over briefly. I think it's really I think most people, when you tell patients, and some of the referring physicians are not familiar with MR or abbreviated MR, when you tell them that in a study of 1,400, there were 1,500 plus women who enrolled, we had 1,440 that were ended up being evaluable because they had follow-up data and they completed both the DBT and the ABMR. That out of that cohort, there were 23 women on the first round diagnosed with cancer. The ABMR detected 22 out of those 23 patients. The DBT detected 9. So it just shows you that for, every patient, so it's about a 2.5-fold increase in cancer detection. So for every one cancer you diagnose, doing your DBT, another 2.5, walk out the door. So it was really eye-opening that, if you think about tomosynthesis, which found an extra 1 cancer compared to 2D, the data shows that tomo compared to analog, compared to 2D, finds an extra 20%, let's say. We're talking 150% increase. This is a massive change in sensitivity, which the other important point is really to foster and move along the dissemination of vascular-based screening, because I think our real issue is, despite improvements in therapies, our biggest issue with our current screening methods is the underdiagnosis of biologically important cancers. And we know through various studies, Janice Sung's paper in Radiology in 2016, that showed MR preferentially detects the higher grade, more biologically important cancers. So, in the past, when we did paired designs or studies, we were just counting cancers. But I think it's really important to look at what I call the biological detection profile of that modality. And is it not only finding more cancers, but is it finding the important cancers? So, so I think the EA1141 trial, and remember the JAMA publication in 2020 was just on the prevalence round screening. And that showed clearly a big 2.5 times increase in sensitivity. And out of the 17 invasive cancers that were women with invasive cancers, the MR detected all 17. The TOMO only detected 7, so 10 additional invasives. And obviously this is not powered, so it's kind of observational. But MR detected the 3 high-grade patients with high-grade invasive, which were all missed with DBT. So I think this is really an important trial to show that the MR is tolerated. It can be performed across all types of sites. It has low reactions and about a 2.5 times cancer detection rate, which I think really is our quickest answer to, still in the United States, over 40,000 women die of breast cancer every year, despite our improved therapies and our, whole breast screening ultrasound and our TOMO. And I think the biggest fix to really almost eradicating mortality from breast cancer is our new vascular-based screening and abbreviated breast MRI, which can really find cancers at a much smaller size and earlier stage. So I think this was a very important phase 2 study to really, and I think it's achieved just, there's a couple of different websites in the United States, but that list sites now offering. And I think we really achieved our goal in that we wanted to advance the adoption of our most sensitive screening test, MRI, by doing a shorter exam, bringing down the cost, making it a similar cost to whole breast screening ultrasound, and thereby, instead of 1 patient an hour, you could do 3 patients an hour on your MR. So really widening the access to our most sensitive test, MRI, to women with dense breast tissue. And I think, seeing these websites now that list, 80, 90 plus sites now in the United States offering abbreviated MR. So I think in that respect, we achieved our goal. I think the next future step with these contrast vascular-based screening methods is, I think it's time, I think the next major study in, obviously the DENSE trial gave us that important information, in interval cancer, reduction in interval cancers as a surrogate endpoint. I think we need even further outcomes-based studies for ABMR to really finalize a change in the paradigm in how we screen. I don't think we're at the point yet where we could say, that ABMR is a replacement, for mammographic screening right now. I still would, use it as a supplement. But I think those outcome studies may highlight the potential for these vascular-based screening methods to be standalone screening tests, if we can have, better outcomes data, and really, I think, show that we can dramatically reduce mortality with these new technologies. So I think there's a lot more to come on both abbreviated breast MRI and contrast mammography in terms of the changing landscape of breast cancer screening, particularly for women with dense breasts, obviously. So more to come, and thank you very much for having me.
Thank you, Chris. This was an awesome tour de force through this study, which is way more than just detecting cancers in dense breasts, which is the core topic of our recommendation paper. It's really fascinating to listen to you and to feel the energy, even in Zoom, how you are emotionally and into the thing. This is really inspiring. And those of you who are sitting at home, please go and read the paper again and again and again, because as you said, Chris, there's so many topics inside. It's not only about detecting, counting like beans, if you wish. It's detecting biologically the relevant cancers. It's also about, you know, workflow issues. So to really cut the MR down to the ultimate essential, which we call abbreviated MR. It's, I think, so important. I mean,
and if I could add, you know, like I said, I felt like this trial is kind of a Trojan horse. Once it gets inside, then, you know, everybody can jump out. And I think eventually MR will evolve back. And I think the more efficient, and I'm working on another MR trial, working on something that I call smart MR, where I think really the most efficient model would be a more robust baseline. Add, you know, some ultra fast diffusion, maybe a pre and 2 posts, you know, a 12-minute or so baseline or 14-minute baseline scan. But then going forward, we just do a pre and a post, looking for change, because, you know, if you have a new enhancing mass, you probably still have to biopsy it versus, you know, even if it has, you know, a high T2 or benign kinetic. So that may be a really efficient model, because then down, you know, many years of screening, patients are getting a 3-minute scan, just a pre and a post. So more to come on that. You know, we have another trial looking, hopefully to start within a year, looking at that design.
Okay, maybe there will be one day a chance to chat again, but I think this time, Chris, thank you very much. It was a pleasure to listen to you. Not that much of a typical interview, really enjoying it. The energy, the contents, it's really wonderful. Thank you, Chris, very much for taking the time again for this long version of the interview, which is going to be on YouTube, but we will find it also on Twitter and Tees and everywhere. If you got any question to us, EUSOBI fellows, but maybe also to Chris, please leave it in our comments. We will forward it to the authors and we'll try to answer them. So thanks very much for joining us again. Thanks very much, Chris, for taking the time. It was a huge pleasure and real honor to talk to one of the giants of breast imaging.
Thanks for having me. I appreciate it.
Thank you very much, Chris.